Good morning, everybody. Welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name is Kevin Lockyer. I'm the Trust Chair. It is customary for us to start our board meetings with a patient or staff story. We do this because we want to hear firsthand from people that are experiencing or delivering our services. It's part of the process of kind of learning from the experience of others. So to that end, I'm really pleased that we're joined this morning by Zoe from Lincoln, who's going to talk to us about her experience of a range of LPFT services and then take some questions or comments from board members. So Zoe, over to you.
Thank you so much. Good morning. I can't see you all, so this feels really odd. But I'll just do a very quick introduction. I'm Zoe Burnett. I am a multi-award-winning international public speaker, best-selling author, and psychotherapist. It's myself specialising in eating disorders. I just want to stop saying thank you for giving me space to speak today. What I'm about to say, it isn't easy, but it matters. Because it's a story about how two professionals whose care did far more than support me. It kept me alive long enough for a future to become imaginable. And they were my CPN and psychologist. For years, I felt invisible within the mental health services, dismissed, minimised, passed between different teams because I didn't fit neatly into a specific box. Felt like a stray dog no one wanted. I felt hopeless and ended up in crisis as a result. Could speak for hours about the failures I've encountered, including my experiences with a crisis team, which have left deep marks. They taught me to expect judgment, not compassion, and I learned to stop asking for help. To believe I was the problem, too much, too broken, too difficult. I told the crisis team about a plan I'd made to end my life. I wanted help. I needed help, and I reached out one last time. And I was told to stop being dramatic. Went ahead with my plan, tried to take my life, and it is thanks to a stranger who found me and rang for an ambulance that I'm here today. After that attempt, I had to fight for support again, and I was finally referred to CMHT. I entered the service cautious, on my knees, and with no trust left in the system. Then I met my CPN and psychologist. Individually, they offered something I'd never experienced before in mental health care, but together, they offered something life-changing, and I finally felt safe. Because it was obvious that they worked together and communicated. And that slowly earned my trust. From the very beginning, my CPN listened, truly listened. Not just to my words, but to the exhaustion beneath them. She honoured my voice when I asked for psychological support. She advocated when I had no strength left to advocate for myself, and she made things happen. She ensured I didn't fall through the cracks again. Psychologists met me very differently in the therapy room. When we first sat down, I wore a mask that I'd perfected over years of survival because I kind of expected to be minimised again. I expected to be discharged if, again, I didn't fit into those boxes. And I was scared. But he didn't push. He didn't force. He simply held that space, steady, kind, and patient. He allowed me to lower that mask in my own time, and he understood why I felt this way and reminded me gently that actually I wasn't the problem. Both of them met me exactly where I was at, not where the system expected me to be. And I began to feel a small flicker of hope. Small? Almost like a flame. I didn't yet trust to last, but with that small bit of hope, healing could begin. With my psychologist, I slowly found the courage to approach the traumatic memories that had been shaping my life in silence, keeping me unwell. And for the first time, I was finally given agency. I was not told, this is what we're doing, this is the modality, you have 8 sessions. No. Instead, I was included, informed, and treated as an equal participant in my own care. And we made a decision together to begin something called narrative exposure therapy. It's terrifying. But with him, the trust had been built, and I felt safe enough to turn towards my past instead of running from it. It gave me safety to explore and feel emotions that were never allowed. A major part of that work involved naming what happened to me honestly, without minimizing it, without making jokes, which I was very good at, by the way, but without trying to excuse it or blaming myself. With his guidance, I started to recognize the true extent of the trauma. And as that truth surfaced, it led to me to consider reporting the offences committed against me to the police. My psychologist held that moment with extraordinary care. He walked me through my options, helped me stay grounded, and made sure that I did not face that decision alone. And because of him, I found the courage to begin the reporting process. To speak aloud what had lived silently in my body for years, and there are no words for what that unlocked. So much more than a step towards justice. It was the moment I stopped surviving my story and began reclaiming it. He helped me finally see that none of what happened was my fault. It was not my fault. The child who learned to stay silent was gifted a voice as she realised someone finally heard her. She wasn't alone anymore. When my psychologist was helping me face my past, my CPN helped me survive the present. She checked in, listened without judgment, created space for the parts of me that were exhausted or overwhelmed by life. She supported me through burnout, through dysregulation, through wobbles I kind of felt ashamed of. Their roles were very different, but their impact was inseparable because together they formed a safety net that held every part of me. An example of that safety net was summer last year, actually. Everything collapsed. Burnout hit hard, and I became severely overwhelmed. I made a quiet, careful plan to overdose. When I was determined to keep myself this time, it felt done. But each time a CPM visited, that plan began to loosen its grip because her presence created pause. Her steadiness softened the spiral, calmly overwhelmed. And when I later sat with my psychologist, that unraveling continues despite my ability to mask. They knew something wasn't right. They saw straight through my defences because they knew me. Eventually, with my CPM beside me, I broke down and admitted the plan. And with guidance and support, I handed over my 500 paracetamol that I've been stockpiling. The following week, the burnout intensified, but the pills were gone. And I know with a certainty that still sits heavy in my chest that if those pills had remained at my house, I wouldn't be here today. Saved my life just wasn't enough of a CPN. I was moved to the crisis house for a bit of respite, and she phoned me immediately and came to see me the same day. When she walked through the door, I cried, not from crisis, but from the realization that someone cared enough to show up. She visited again later that week. She responded to every voicemail. She anchored me while I stood in the middle of a hurricane. And that visit changed something fundamental in me. Reminded me I mattered. That was worth showing up for. Someone cared, truly cared. She kept that flame alight, and together they gave me safety, consistency, autonomy, truth, compassion, but most importantly, and I know it's cheesy, but it's true, they gifted me hope. Steady, grounded hope. Hope that I do deserve a future, one I never believed could belong to me. Moving forward, I've been discharged from psychology due to, limited sessions, an ending that arrived too soon. My psychologist walked with me into the darkest corners of my mind, switching on lights in rooms sealed for decades. Together, we unearthed memories I buried simply to survive, breaking me completely down. And then at the very moment rebuilding should have begun, the sessions had to stop. And I want to be absolutely clear here. This was not the psychologist's choice. He'd already advocated for extended sessions because the extent of my trauma warranted a longer term support. He did everything he could within the limits he was given. The barrier was not the practitioner, the barrier was the system. A psychologist gave me solid foundations, but they are only the beginning of recovery, not the end. What follows is rebuilding identity, learning how to live beyond survival, finding out who you truly are. And that stage is fragile, really essential, and exactly why the system kind of stepped away. Ending therapy at the moment, rebuilding begins. It's neither clinically sound nor cost effective because it increases risk of relapse, not because the therapy had failed and not through lack of trying, believe me, but because the scaffolding was removed too early. It felt like being walked out of a burning building and then told to rebuild a house alone. Despite that, I remain deeply grateful because, again, the foundations my psychologist helped me build are solid. But this gap must be acknowledged, not buried beneath outcome data. Looking back at my journey, there were many moments I didn't think I'd survive. Hope felt distant, life felt heavier than I could hold. Today I can say something once unimaginable. Glad I'm alive. They kept me here long enough for me to realise that life is something I want to stay for. I am aware of time, so I will end with this. I'm not an outcome measure or a line in a report. I'm a life that should not be here, but is. And the reason I'm here is it's not because of a system or a policy. Systems save no one. Policies do not soften spirals. Humans do. And I stand here today because 2 members of your staff chose to be human first. They refused to let me fall through the cracks after I'd already been let down too many times. They listened when others had turned away. They stepped into places where fear had lived, offered safety where silence had been, and again, gifted me hope. I'm here breathing, choosing life, because when my flame was almost extinguished, they protected it, tended it, and kept it burning until I was ready to carry it myself. Because of them, my life didn't end last year. Because of them, my daughter still has her mum. Their work is not simply clinical. It is profoundly life-altering. The NHS is stronger, braver, and kinder because of people like them. Thank you. Happy to take any questions.
Thank you very much, Zoe. Thank you for being honest and open with us and giving us some very powerful messages. I'll invite colleagues who may want to ask you questions or comment in a minute. There's a couple of things for me that these are observations rather than questions, Zoe. So don't particularly expect you to respond because you've made your points, but you're welcome to come back on anything that I say. For me, I mean, you highlight 2 or 3 sets of issues that are that we've been wrestling with as a board for a while, and which we haven't got right, but we are at least trying to get more right than wrong. The first is how well we listen to people. And that's not as individuals, that's as an organization. We've done a lot of work to get better systemically at how we listen to patients, service users, and their families, but we haven't got it right. We don't get it right all the time. We're honest enough to admit that, but we're also honest enough to admit, that it's a problem that we want to do something about. Second is how we get better at passing people between
Mm.
services. We are terribly bad at that. And one of my, personal perennial, it seems like perennial issues is that sometimes we act like a collection of individual services rather than an integrated organization. Um, and we're getting better at that, Zoe, but we're nowhere near as good at it as we should be. And what you've done this morning is illustrate the fact that that's not just an abstract managerial problem; it's a problem that affects real people and real lives. So, we need to redouble our efforts and get better at that. Because thirdly, we talk about there being no wrong door, and that's absolutely the right philosophy. But then we undermine that philosophy by acting like a bunch of semi-detached services some of the time. So, none of the things that you've said, and I hope this comes as a bit of reassurance to you. None of the things that you've said will come as a
Mm.
surprise to us. But what you have done, I think, is two things: highlight the fact that those problems, as I say, don't exist in the abstract. They affect real people like you. And secondly, that we've got a way to go in getting as good at across those issues as we should be. So thank you for reminding us of that, and thank you for as it were, personalizing what otherwise become conversations that can take place in the abstract.
Okay, I was going to come back to point two, if that's okay,
Of
regarding
course you can, and then I
passing
can see that there are
between,
colleagues that
bless
have
you,
got comments they want to make. So go on.
yeah, just passing between the different services. What happened was originally to go to my GP and referred to talking therapies. However, the wait list obviously was like a year and a bit. So I was on a wait list for ages. And then I ended up, I had to choose between anxiety or depression. I was like, it's neither of these things, it's trauma. But I wasn't allowed to access the trauma until I'd been through this. So it's a waste of time. Anyway, so I had about 3 sessions and she was like, yeah, you shouldn't be here. You need the other service. So again, I ended up going back on a waiting list for ages to then go for another service for them to tell me that I was in the wrong place, which I knew. But then I was discharged and then passed to a different service who again told me that because it was complex trauma, not just normal trauma, that was in the wrong place. And then they just completely discharged me because the service I needed didn't exist apparently. So I was just after about 2.5, 3 years of just past, I was completely left, hence the crisis. So yeah, I hear you.
Yeah, and I hear you too. And all I can say, Zoe, is that I'm sorry that that happened, but we are working hard to try and get better at it.
Thank you.
So that I don't hog you completely, I'll hand over to colleagues. So Sharon first.
Thank you. Hi, Zoe. My name's Sharon. I'm the chief nurse for the trust. So I'm a mental health nurse and a learning
Yes,
disability
familiar. Carry on.
nurse. Firstly, thank you. It's really important for us to hear the good bits as well as the bad bits. And obviously we often hear, certainly in my role, I often hear when things have gone wrong. So to have you explain your experience in such a heartfelt way, I think is really important for us to hear, and also kind of hits you right in the heart, really. One of the things for me and through the work that I do in my role is to try and keep talking around the importance of hope. And my clinical background's working quite a lot with people who have experienced psychosis and strange and unusual experiences, who have often lost a lot of hope and are really frightened for what their future looks like. And I think you're right, and you articulated it so well around people aren't outcome measures. Policies don't necessarily mean much to you when you're in the depths of despair and really trying to get through. And I think there's something for us around how we balance the two. There's stuff we have to do, there's things that we have to work in terms of how we make organisations work. But fundamentally, that the strongest thing you can do as a clinician is build that relationship and hold the hope when those around the care of the loved person have kind of lost that. And I think there's a lesson in there for us. I'm sorry that it feels, and it has been, that you haven't had as many sessions as you'd like. It's something we're really grappling with, trying to get the best care for people. But certainly there's obviously constraints on us. But again, thank you for being so balanced with that. My question, and I know that was a bit of a ramble, but I really wanted to share how much that had meant. My question was around, obviously this is an opportunity for the whole of the board of directors to hear from you. And I didn't know if there's anything sat there that you're thinking, I really wish they'd know this. Like, you've given us some really strong messages, but I just wondered whether there's anything that you would like us to take away, given you've got kind of the whole range of the board here. I just wanted to give that opportunity.
Yeah, I've focused mainly on, because as people we're quite quick to kind of complain, if you like, and not focus on the good stuff. So we can get it right, absolutely can get it right, and that's proof. But kind of going back to the crisis support, if you like, I only gave a little example of that crisis team. However, entered the crisis house to begin with ages ago, and they discharged me with no follow-up support. I was literally in and then left, tried again, and it was as though I was being a pain in the arse, excuse my language, but that's how it felt. If I had to ring them because I was severely struggling, I remember being met with sighs, going, oh, hello, like, and it was like, oh gosh, I'm sorry. Again, because of my job, because of my profession, I got accused of, well, you should know what you're doing, you're a therapist. I'm like, how dare a therapist need therapy, right? Apologies. But every contact I've had with the crisis team has made me worse, I'll be honest, to the point where if I was in crisis now, I don't know if I could reach out because the fear, I guess, massive fear of being minimised or dismissed or not heard or ignored. And I had to put a powers complaint into MUAC, but I have had a meeting with them and we have kind of come up with some solutions regarding that, because I entered MUAC one evening in absolute bits and they basically said, well, what do you want us to do? You're under CMHT, you're in crisis now, but you have therapy in 3 days' time, so go talk to your therapist in 3 days, despite the fact of me being in a mess then. And they literally showed me the door whilst I was having a panic attack. No effort to calm me down, no regulation, no. They tried to do a safety plan whilst my window of tolerance was absolutely off the chart. So, yeah, the crisis support, it's a little bit messy, shall we say, at the minute. And I'm aware it's possibly an ongoing thing, but I just wanted to get that in there as well. Lost faith in it a little bit.
I really appreciate you being so open about that, Zoe. Thank you.
Thanks, Sharon. Sarah.
Thank you. So morning, Zoe. I'm Sarah Connery, Chief Executive here at the Trust. Thank you so much for bravely sharing your story today. And you speak, you don't need me to tell you this, but so eloquently and powerfully. I think we were all hanging off your every word, if I'm honest. So thank you very much for, as Sharon says, being so balanced as well. We do often hear about when things have gone wrong. So it's great to hear about when things have worked for you. And Sharon's right, we do have, we work within finite resources. We have to ration, I guess, for want of a better term, the support that we provide. But even though we'd rather not, but that's where we are. But the one thing I think we can do, which it sounds like that you've got right with your CPN and psychologist, is that therapeutic relationship. And where it isn't a therapeutic relationship, that's where it's not effective. And it's something that we've been talking about a lot as a board and in our care groups around what's our sort of philosophy of care and how do we know when we've got it right for people. And I think you sharing some experiences around crisis care, we haven't got it right for you. So it's just if you were sitting in my chair, I suppose, in terms of what might help, if there's anything that you think, oh, I wish someone had just said this to me, or like you say, if you just shown the door with no support, that's quite a lonely place to be, isn't it? So sorry to put you on the spot, but if there's anything that we can sort of take forward as of tomorrow to help improve, thank you.
Yeah, no, absolutely. Sorry, if you see me doing this as you're talking, I'm not ignoring you, I'll just jot notes down.
Absolutely
extremely
fine.
neurodivergent. I have ADHD, and that ties into what I'm going to say actually, because one of the things that's become quite apparent is, again, Callum, Ariane, oh no, CPN and psychologists, I wasn't supposed to name their names, my bad, were absolutely incredible and knew how to work with someone who is neurodivergent. And one of the things I really valued was before I started working with my CPN, didn't name the Sam, we had like an intro call almost. She came over just the once, just to kind of, before we even started anything, just to introduce herself, just to kind of say, look, this is sort of thing we're doing. Do you have any questions? If you do and you can't think of them on the spot, that's fine. Pop us an email, it's okay. So that little before we even started doing anything, that reassurance, just go, oh, this is what to expect. You're the person I'm going to be working with. Okay, it gave me a chance to think of any questions again before we started that work. The same with my psychologist. We didn't dive straight into, obviously. The first, again, it took me ages to kind of actually settle down. So the first 4 or 5 sessions almost were me like, no, there's a wall here. No, go away. Because again, that's understandable. But again, taking that time to get to know the person, I'm not just a label, I'm not just an illness. I'm a person as well, right? Talking about what their interests are and getting to know them. And again, that can be really, really important for therapy later on down the line anyway. Because if you know the person when you're talking about coping skills, for example, both practitioners knew that I liked painting and playing the flute and surf and all these other things because they knew me. So if I was in a bit of a tiz one day or being a bit of a, narc, I'll be honest, they'd be like, oh, have you been painting anything recently? And, again, because they knew me as a person, it wasn't just go and have a bath and a walk because, no. So again, that therapeutic relationship is, in my eyes, as someone with little experience and a psychotherapist myself, is the fundamentals, really.
Thank you, Zoe.
Thanks, Sarah. I've got Mike and then Eve, and then Zoe will let you go to enjoy the rest of your day. So Mike first.
Thank you.
Thanks, Kevin. Thanks, Zoe, for sharing all that. Really appreciate it. I'm Mike Hunter. I'm the Chief Medical Officer. I'm a consultant psychiatrist by professional background. It's a common, because you really sort of made me think differently about a couple of things while you were talking. The way you spoke about the past and the present really seemed real. And it made me think, because you talked about invoking hope as well as being a crucial thing. And that made me think about the past, the present, and the future, really, of trauma being the past, getting through, as you said, including crisis being the present, and that retaining a sense of hope being the future. I'd never really thought about a kind of past, present, and future way of framing how we do mental health care before. So I'm going to take that away and just sort of like mull it over a bit more. Particularly mapping onto the aspects of trauma. This year, we're going to be much more specific about setting out our philosophy and foundations and principles of care. And we're not starting from nowhere, because the board has previously looked at and agreed a philosophy of care, and that principle about being trauma informed is in there. And maybe this is a question, actually, or maybe it ends up being a question, because quite often when you speak to people who've experienced trauma, they say words to the effect of, every service, no matter how unhelpful it ever was previously and remains now, has got a sign on the door saying we're trauma informed. But when you dig into that, you don't really find very much. And people say things like, what we really need is something that's trauma specific and is trauma competent. So my question is, I wonder what you think about that. But the other thing I just wanted to kind of think about is, quite often the trauma models, you're a therapist, so you're familiar with the kind of diagrams that people draw about how people might get triggered and how you might help and so on. And I just think there might be value in speaking with you and people who've had similar experiences to almost put it the other way around as well. So how can I put it simply? A conversation with colleagues along the lines of, if you do find yourself wanting to show someone the door, what's going on there and how do you make sense of it rather than just do that. But that question about what do you think about that trauma informed and how we dig into it and make it meaningful, not just a kind of buzz phrase.
Yeah, I'm not going to lie, I didn't mean to pull a face when you said trauma informed. I do apologise. It is a word that gets thrown around, but what does that actually mean? Yeah, we can go on courses and understand what trauma is and how it affects someone and maybe doing about flashbacks, stuff like that. Fine. However, again, we need specific therapies, if you like, and interventions that actually help those with trauma. So again, the psychologist I had was trained in something called narrative exposure therapy, which I'm also trained in. What to expect? Rewind therapy, EMDR, just a range of different therapies. And again, I think I got lucky with my psychologist because he was trained in different specific modalities. So we could go through the options, we could decide together which one might work best. So yeah, getting trauma informed is fine, but where's the actual services to deliver the interventions that we need?
One thing, if I may,
How easy is it to get into them?
One thing, if I may, that's given me real optimism is I've been here 3 months and I can see that we're doing training in LPFT for our teams in the power threat meaning framework, and I can see teams using that. And I've not seen that in other organisations. That makes me honestly feel optimistic that there is a real drive to dig under the trauma informed thing and really put some meat on the bones. Thank you.
Yes. No, thank you.
Thanks, Mike. Eve.
Thank you, Kevin. And mine will be very brief, Zoe. So I'm Eve Baird, I'm Chief Operating Officer. So all of the clinical services kind of fall in my portfolio. I want to apologise to you for your experience of crisis services. That's not what we would want for someone when they're at their most vulnerable and at their most crucial time of need. And I'm really sorry that that was your experience. We are doing some work at the moment across our community services and our crisis services to look at how we can build in additional capacity in our community services so that we have the opportunity to step up as people who are already accessing services and already have meaningful relationships can access enhanced support from the same people who provide their support in a routine way. And so we're not there yet. We're in early stages of conversations. As lots of people have said, we've got limited resource and we need to think about how we best use that resource. But the way that you've spoken today is a really powerful reminder of the impact of a meaningful therapeutic relationship on someone's ability to hold hope and ultimately on their recovery. And I think it's reinforced for me that we need to drive that work forward and really think about how we can have more step up, step down models rather than separate approaches to somebody when they are in their routine state of being versus when they're at their most vulnerable and in the most need. So I just wanted to let you know that we are doing that work. If that's something that you'd be interested in contributing your personal experiences to, I'd really welcome picking that up with you outside of here. But again, I apologise for your experience because that isn't what we want.
No, thank you so much. Yeah, we'll just step up, sorry, I'm aware of time, I do apologise. We've just step up, step down as well. We spoke a little bit earlier about obviously services working together and communicating and instead of being set things, if that makes sense. And again, one of the things that CMHC did really, really well was when I was stepped up, I had a meeting with CPN and I had an IBPT worker for about 2 weeks before they realised I needed stepping up. So I told them originally, but it's fine. But again, we had a joint meeting, a joint handover. So it wasn't just, oh, you're over there now, here you go. It was a gradual, again, neurodivergent brain. It really helped that, okay, this is safe feeling. But yeah, absolutely. And the offer goes to anybody really on the board. If anyone had any more questions or wanted to pick my brains, I am more than here for that. It's absolutely fine.
Thank you very much, Zoe. That's a very kind offer. And if you've taken any reassurance from the conversations we've had this morning, I hope it's that as a board, you know, we want to listen, and we want our services to be better. So I am sure that there are colleagues that will want to have, you know, further conversations with you. So, you know, other people have said thank you, so but I'm gonna say thank you as well. So, you know, thank you for coming this morning, Zoe. I am, you know, personally sorry that your experience of our services hasn't been, you know, all that it could have been and should have been. But I am glad that, you know, you finally found the right place and the kind of right support, and that it worked for you. So I'm, you know, I'm pleased about that at least. And thank you for being open and honest with us this morning.
Again, thank you for having me. I do appreciate it.
No, absolutely. It's our privilege. Thanks, Zoe.
Bless you. Okay,
Right,
I'll
take
leave you
care.
to it. I'll pop out. But yeah, enjoy the rest of your meeting and take care. Thank you.
Thank you. You too. Thanks.
Thank you. Thank you.
Right then, let's move on, if we can, to the substantive agenda. Apologies for absence. We've got apologies from Tim Harry, Amy Beaton, and Mark Platts. Declarations of interest are as recorded formally. If anybody's got any other declarations they want to make for purposes of this meeting, then do please let me know. If there are none, we'll move on to the minutes of the last meeting. Last meeting of the Board of Directors was held on the 11th of December. Are there any comments on those minutes, either in terms of factual accuracy or matters arising? Please let me know if there are. If there aren't, I'll be grateful if colleagues just please indicate that they're happy for me to sign them as an accurate record. Thank you. Schedule of actions and follow-up. Well, schedule of actions is very small, but perfectly formed. There is absolutely nothing on it at all, so we'll skip lightly over that. I don't have any specific remarks to make from the chair that aren't going to be picked up otherwise in discussions on other issues. So having said that, I will then defer to the Chief Executive for a report. It's item 2.1 on the agenda. Sarah.
Thank you, Chair. Thank you. Morning, everybody. I'm Sarah Connery, Chief Executive here at the Trust, and I'm presenting today my usual overview of key national and local issues that may impact on our Trust strategy and plans and priorities. So I will take the paper as read, just to flag a few key highlights, which is there are a number of national reports which sort of relate to mental health, mental illness, neurodivergence, which some of them are ongoing, some of them have been published and waiting a government response. I also importantly want to say that the Mental Health Act has now, the refresh has been received royal assent just before Christmas. So we look with interest in terms of the implementation plan going forward. As we spoke about previously, this isn't going to happen overnight. It's quite fundamental changes in terms of the legislative framework that we're working in. Really important guiding principles within that act, as we spoke about previously, which ties into everything that we've just heard from in terms of Zoe's experience around choice and autonomy, least restriction, making sure that any admissions have therapeutic benefit, and importantly, treating the person as an individual, which is everything that we talk about in terms of our outstanding quality pillar within our Trust strategy. So it will be sort of an 8 to 10 year implementation phase, and really pleased that we have our newly formed mental health legislation committee, so we have a home, so to speak, to make sure that we've got touch points around the impacts of that. Also just want to say we've had quite a bit of activity around the Care Quality Commission, so a few reports which have now been published. We've had an outstanding rating for our Lincolnshire Secure Unit, and requires improvement for our rehabilitation inspection that took place before in 2025. So as I've covered in my assessment, my executive assessment, we really welcome the additional oversight and objectivity that assessments are bringing to us. We want to be a learning organisation, and having the CQC support us with that, you know, we really welcome. Some of our ratings are dated over 7 years old, so there will be lots more inspections to come. We've had a visit this week, an unannounced visit to our low secure unit. So a lot of the activity will be just because the ratings are, you could say, out of date, for want of a better turn of phrase, rather than any significant issues that have been highlighted to them. But we welcome all feedback, and we'll make sure that we're responsive to any recommendations and learning accordingly. In terms of some good news, we've got the Lincolnshire Unit for Mental Health Research has now been formally notified to us. So that's £11 million over 5 years of research funding, which will really help us shine a light in terms of what works and what are the challenges around mental health provision and population need in a rural and coastal county like Lincolnshire. So really excited about that. Just to flag to the board, it is our virtual research conference in March, so it'd be great if people can attend, but we will record to make sure people can access that if unable to make it. Also want to use my privileged position as the executive sponsor of our LGBTQ+ staff networks, that it's LGBT History Month this month, and we're, as usual, putting on a great programme that people can access virtually in terms of learning and celebration of our LGBT community. Again, if people aren't able to attend, they are being recorded so that people can access them at their convenience. Also, just want to say a massive thank you to all of the staff who were engaged in us being able to launch our new staff safety hub, which we went live with at the beginning of January. So this is in response to lots of feedback that we've heard from staff around how we can support them and their managers following an incident, to make it easy for people to receive the right support following an incident. And we'll be really keen to hear about people's feedback from, it's quite early days, but in terms of feedback and how that's felt for people to access that support. But a big thank you, because it has been a real co-produced effort with people who have been on the receiving end of violence and aggression from our patient population. Just finally, we're really excited about our awards ceremony, our Team LPFT Values Awards. A huge congratulations to everybody who is nominated, and particularly to our finalists. So the award ceremony will be virtual this year on the 28th of March. And we're really looking forward to announcing our winners and celebrating all the great stuff that our staff do each and every day, as again we've heard in terms of Zoe's story this morning. I'll stop there, Kevin. I could go on, but hopefully the paper is helpful and clear, and I'm more than happy to take any comments or questions.
Thank you, Sarah. Your reports are always clear and comprehensive. A quick question from me before I bring in colleagues on the shift to care groups. Sarah, what arrangements have we got in place to evaluate the impact?
That's a really good question, and I'll invite Eve to come in around that, if that's okay.
Thanks.
Thank you. I'm on now. Eve Baird, Chief Operating Officer. So in terms of the move to care groups, obviously at this point in time, we're still embedding that, and a lot of the a lot of the impacts of that change is actually on our digital and data colleagues and our reporting systems, so the structures that are all set up in the background. So there's been a lot of work going on over the last 6 weeks to make sure that all of our reporting, whether that's performance or workforce or payroll or rostering, is all aligned to the new care group structure. What I'm planning to do is, once we get there, kind of set a date for this is now we are established, which we've got the first round of care group oversight meetings happening this month, and then do a review at 6 months of actually how is this working, how's it feeling, are we delivering on the ambitions that we set out, which was clearer lines of accountability and oversight, more equity in terms of board oversight, and less layers between point of care and board. So we can do that review 6 months after, but I'm thinking that will probably be September time to give us a full 6 months of working in the new way.
Okay, that's really helpful, Eve. Can I ask then that we have a report to board that gives us at that 6 month point an initial assessment of how the transition has worked? And I think it would be worth giving a little bit of thought to, what benefits we want to see realised and how we would judge whether or not they're realised. So, we want it to have an impact on, on clinical leadership and better integration and all that sort of stuff. So it's, how will we know whether or not we've done it? But I think, an interim kind of poke about at that in 6 months' time sounds like a sensible thing to do. Great, thank you.
Thank you.
Di.
Thanks, Kevin. Thanks, Sarah. Can you hear me? Because I don't seem to.
Yeah, can hear you fine, Di. Yeah.
Good,
and now we can
good.
see you as well.
Right. Okay, that's great. Thank you. So thank you for the report, Sarah. Yes, clear and very useful as always. And I just really wanted to say great news about the research success. That is something as a non-exec I feel very strongly about, so really pleased to see that. I should have said Di Bailey, non-exec director at the start. Apologies. My questions and comments really relate to the piece in your report about the alliance, and I read the report that was appended to your report, and I think it is really impressive in terms of the amount of work that is going on across the alliance. But I guess there are a couple of things that sort of stood out for me. One was, I think, given the scale of what was being undertaken, I suppose I was quite underwhelmed by what I saw in there around impact. So I think there was one piece where there was mention made about the impact of an initiative in Leicestershire around use of restrictive practice, where there were some, where there was there's an evaluation that had been done which had reduced restrictive practice by 40%, which I thought was absolutely great. So obviously keen to understand how that can be scaled up across the alliance, but I guess overall I just felt I didn't get a sense of the impact, and from a non-exec perspective I'm not sure how much of that impact we see in our committees. And so my question was around, so my first question, I have two questions. My first question was around how do we grasp that impact and and benefit from it a bit more maybe than we are currently, if so. That was one question. My second question was, I appreciate the report was looking backwards, but I'm also aware, and you've mentioned it, around the activity in our trust around CQC. I'm conscious of the CQC activity in some of the all of the other trusts that sit within that alliance. The challenges are across the piece, and so I just wonder going forward how collectively we might work to share some of those challenges that are being pointed out to us in terms of that strategic positioning around improvement.
Yeah, Okay, yeah, there's quite a bit I think that I could respond on. So just stop me if I go off on a bit of a tangent. So I think that's a really fair challenge, and I think I guess I struggle in terms of what the board might want to see, because as part of we do have a sort of, we call it a joint board, but it's not really a joint board, where all of the provider collaboratives are sort of reported on. So I report on our Op Courage contract, for example, and Leicestershire do the same around adult eating disorders. There is a lot of data in that, but probably what we could do a bit. So there's a lot around reducing out of area, reducing, as you've mentioned, restrictive interventions, insecure services. There's been a quite a significant drop around long-term segregation and seclusion. So the activity is there. It's just how much do we feed through to the board? And what I don't want to get to is the well, so what question, and let's pat ourselves on the back. So, but I think myself and Kevin are going to have a chief executive and chair session with all of the providers. It's coming up in the next few weeks anyway, in terms of a point where we can connect and talk about, you know, what are we doing moving forward together, and how do we want, we've tried doing annual events where all of the non-execs are invited, but you know, it's hard to find somewhere appropriate for everybody that works for everybody when it is such a massive geographical area, you know, 5 million population that the Alliance serves. So I think that will be a good conversation. Absolutely agree with you on the point around Care Quality Commission activity. I know Derbyshire had a whole week's worth of visits last, you know, the week before last. So we're kind of informally sharing the intelligence, but what I have said is actually we need a special session on that, potentially through the chief nurses and chief medical officers group, where it can be, you know, if we have CQC and they say, well, we've found some issues with this bit of physical healthcare monitoring paperwork, I'm straight on to my chief exec colleagues, go, this is something, you know, please do have a look at this. And so we've got that informal network, but I think we need to probably tighten it up and make it a little more formal from that point of view. I think what the issue that we'll always have in terms of impact through the alliance is we don't have any additional capacity as a result of being an alliance. It relies on, you know, the chief people officers, the chief nurses, the chief medical officers to go, right, I'm taking that learning and I'm doing something in my own organisation. And, you know, hopefully the paper will present that, you know, there's a lot going on and capacity is thin. So it's what we make of it, I suppose. But in terms of the forward plan going forward, we will have another annual event and there'll be a dedicated session on, right, what do we want to work on going forward, hearing from all board members, including non-executive directors, you know, where do we want to use our limited capacity, where it will have the greatest impact. So sorry, I will stop at that point. One area that we have been achieving really well is, of course, reducing, if you look at the pie of spend in terms of our mental health spend, what we want to do is reduce the specialist out of area spend and put more into the community. So as a result of the work where we, you know, Lincolnshire was a front runner in terms of putting a tier 3.5 service in, the other counties have done similar. We've attracted 12 million in national funding to be able to do that. We're now seeing quite a significant reduction in inpatients for children and young people at tier 4, which is great. Yes, we're now working on our business case for a children and young people's daycare service, which is exactly what came through our transformation work with the council, and that's what children and young people and their families are telling us. That's what we need in Lincolnshire. So we're working on the business case for that, which I'll bring into a future board report as it moves forward. But we're hoping that will be live before the autumn. Hopefully that's helpful.
It is helpful. Thanks, Sarah. Thanks, Kevin.
Thanks, Di. Just a couple of quick observations on that point, Di. We haven't. I don't think we've got board and kind of committee engagement with the alliance, right? And Sarah, you know I think that, but and you know, we've worried at this for some time and not found the right way of, you know, kind of engineering that engagement. I remain convinced that an annual event isn't the right way of doing it. But as you say, Sarah, we're having this chair CEO conversation. So, you know, I hope that we'll get something out of that kind of re-energizes how we think about this. But I think they're fair observations from Di. Mike.
Thanks. Two unrelated things in relation to what we're talking about now. Just to say that Sharon and I were at the CMOs and CNOs Alliance meeting this week, and we played in deliberately from LPFT that we needed the shared learning from our collective regulatory experience on the future agenda. So that's going to happen. In relation to the previous point about moving over to care groups, it just struck me that of course, we'll get an evaluation and that will be really helpful. While this transition is taking place, and I know we're going to come to the integrated performance report later on the agenda, but I'm just looking at page 12 of that report on a whole list of KPIs to do with incidents, complaints, length of stay, supervision, training, and so on, which are the things that we'll be seeing at board during this transition period and that the subcommittees will see more granular detail in, so we'll be able to monitor impact to an extent through these well-established governance processes.
Thanks, Mike. That's really helpful and right, of course. No problem, Di. Di's just dipping out and coming back again because we've got connection issues. Thank you, Sarah. I don't see any more questions or comments. That's been really helpful.
Thanks, Kevin.
Useful discussion around alliance-related stuff.
Yeah.
We'll move on then to item 2.2, which is the Board Assurance Framework. Karen.
Thank you, Chair. So I'm Karen Scott and I'm Trust Secretary at LPFT. This is the board's quarterly review of its board assurance framework. I'm going to take the paper as read, but just draw out one or two key points of note. Specifically, that other than the outstanding quality domain within the board assurance framework, there are no proposed changes to scoring, and I'll come back to those in a moment in specific relation to the quality domain. But just going back to healthy population, prior to the board establishing its new board level healthy population committee, those areas or elements of the board assurance framework had previously been scrutinised and monitored by the best use of resources committee. But since the new committee's establishment, obviously those elements have now transferred, and that committee has now met this year for the first time. So moving forward, those will be identified separately. Moving back to the outstanding quality pillar, the proposed change to the current target scores for outstanding quality 1 are a reduced current score from 16 to 12 and a target score from 9 to 8. And the quality committee discussed that at some considerable length, but ultimately was satisfied that it had sufficient assurance that action had been undertaken to facilitate that reduction at this point in time, and it is just a reduction, so that will be monitored closely moving forward. In terms of highest scoring risks, those are outlined within the paper, but those risks particularly span a number of areas, namely financial sustainability, environmental compliance, digital infrastructure, operational effectiveness, quality of care and patient experience. Quite a lot to unpack in that. The report has been given previous scrutiny as is set out by each of the respective board committees in their quarterly meetings, and then subsequently by the Audit and Risk Committee. So it's here now for the board's review and to consider whether it has sufficient assurance against the actions being taken regarding those risks, whether or not it can sign that off today, Kevin. Thank you. Happy to take any questions or comments.
Thank you, Karen. Questions or comments for Karen, please, particularly focusing on the point around whether or not we've got sufficient assurance to sign off on the report. So I don't see any questions or comments. The implication from that is that colleagues are content that this gives us sufficient assurance around the management of the risks identified. And all of these have been through, some rigorous consideration in board committee, haven't they, Karen?
They have, yes. Each of the respective board committees scrutinise this at each of their meetings, Kevin. And as I say, then audit and risk committee then give it a complete oversight and review. So yeah, I think there has been robust review up to this point.
Okay, so I've got colleagues in chat saying yes, that they're happy with it and it's a very thorough piece of work, which clearly it is. So I think you can take it then, Karen, that board has approved that. Thank you.
Thank you.
Shall we stay with you then for item 2.3, which is the review of risk appetite?
Yeah, thank you, Kevin. So, as you say, this is the board's annual review of its risk appetite. Just by way of context for those observing the meeting, as set out in the report, the Board of Directors undertook a comprehensive review of its risk appetite back in 2024, and actually that resulted in some significant change to the way in which it approached its appetite, the format, and actually aligning that to the trust strategy and the pillars within the strategy. Seemingly now a lot of its documentation now aligned along those pillars. So at a very recent board development session in January, the board had the opportunity at the same time as considering risk more generally to consider its risk appetite, and as a result of that there is no proposed change to the current risk appetite as presented. There are a couple of recommendations within the report, Kevin, just for the board to consider. So just to highlight the continued use of the existing risk appetite, its ongoing use and the matrix in all board and committee papers, and some small amend within the trust reporting and management of risk policy to indicate that the most recent review of the risk appetite. So a number of things rather than just one approval. Thank you, Kevin.
Thanks, Karen. Any questions or comments on that? The risk appetite, the unrevised risk appetite reflects the conversations we had at board development a few weeks ago. If there are no questions or comments, if colleagues can indicate whether or not they're happy to sign that off, that would be great. Fabulous. Thank you very much. We'll move on then to item 3.1, which is the highlight and exception report from Quality Committee. Sarah.
Good morning, Sarah Whiteman, Non-Executive Director and Chair of the Quality Committee. We met on the 20th of January and were quorate. We had another inspiring patient story from Ash Villa, demonstrating excellent multidisciplinary working and clinical bravery in supporting a complex discharge. On staffing, the committee endorsed the Havenside ward uplift on patient safety grounds and recommends that the board approves that. We were encouraged by the flu vaccination uptake at 46.6%, which was close to the 48.2% target. We approved terms of reference for 4 Tier 3 subgroups, reflecting the strengthened governance architecture. Areas where assurance remains limited include complaints capacity, where team turnover has created pressure, although recovery is expected this month. An increase in moderate harm incidents where classification consistency needs attention, and paused 15-step visits, reducing real-time ward assurance. We also supported the Chief Medical Officer's commitment to redesign the Learning from Deaths report to be more learning-led, and backed the development of a comprehensive clinical audit plan for 2026 to 27. Overall, we feel the committee is seeing genuine governance improvement and wants to ensure that this translates into sustained operational impact. Thank you, Chair.
Thank you, Sarah. That's really helpful, and you know, obviously absolutely the right focus for the committee. Any questions or comments for Sarah? If not, we will note that. Thank you very much, Sarah. And we'll move on to the highlight and exception report from the Mental Health Legislation Committee. Di.
Thanks, Kevin. Di Bailey, Non-Exec Director and Chair of the Mental Health Legislation Committee, which, as Sarah mentioned in her report, is a newly created committee, and we met for the first time in January. In terms of, as it was the first meeting, we spent quite a bit of time reviewing the terms of reference, and we reached a position where I think we felt that whilst the committee was embedding, we would continue to review those. I think we made a good start in terms of agreeing the focus of the committee and the key performance indicators that we will look at going forward. We agreed should have a balance between reporting that looks at compliance with our legislative framework, whilst also looking at that within the context of promoting least restrictive practice and best patient experience. So we're not rushing to come up with those key performance indicators until such time as we feel that we've got that right balance in place. So watch this space. We are adopting that approach as well because of the changes to the Mental Health Act going forward, given the approval of the Mental Health Bill in December 2025. So there is a future focus to our work as well as the present in terms of what we're doing. And Kevin, one of the things that we agreed as a committee was that it would be useful to bring that future focus in terms of what the changes to the mental health legislation mean for the board to a board development session in future, so that the board can be fully sighted on the alignment between that and the direction of travel of the committee itself in terms of the more sort of operational reporting. I'll stop there. Happy to take any questions.
I think that sounds sensible, Di. I think we'll need a bit of clarity about what the implementation plan looks like to make sense of that, because we don't want to get ahead of you know, whatever the government's thinking is in terms of commencement and implementation. But that, you know, in principle, that sounds like the right thing to do. And it's good to see, you know, the committee, you know, it's a new committee, and it's you know, taking care about you know, how it approaches the task. So that's not surprising, but good to see. Thank you, Di. Got a comment from Mike.
Thanks. And as Di says, we will process this properly through the governance of the committee and then bring to board what this means for us and what our teams need from us and able to implement these changes properly, legally and safely. I think there's no harm, though, in also just having a heads up about what this year will and won't look like. I think the legislators and the government have been very clear in setting out that this is the consultation year. So there are a few things will happen, but not many things will happen. It will mainly be consultation with a view to producing a code of practice about 12 months from now. And when the code of practice will inform the more detailed implementation plan.
Yep, understood. Completely get that, Mike. Thank you. Thank you, and don't see any other comments or questions, Di, so thank you very much. Note that. We'll move on to item 3.3, Sharon, which is the annual report on feedback from board and committee stories.
Thank you, Chair. I'm Sharon Harvey, Chief Nursing Officer. So each year I bring this report through to the board for discussion so that we can have a collective look at the patient and carer stories and staff stories that we've heard through the board of directors. I'll take the report as read, but there's a couple of key bits I want to bring out. So this report's also included capturing the stories that we've started to hear through Quality Committee, and this report has been through Quality Committee, as Sarah said earlier, for discussion. Some of the key discussion from the Quality Committee was how important it is for us to continue with hearing patient, carer and staff stories, but also how we can make sure that we are making it as easy and as safe as possible for people to be able to tell their stories in a way that is meaningful for them. So one of the recommendations from the committee was that we undertake a piece of feedback, both from members of the board around the value that you feel we hear through these stories and any areas for improvement and how we can use the stories and hear them, but also from people who have either declined to share their story or who have shared their story. Is there a way for us to make meaningful adjustments to make it as easy as possible? And also the recommendation that in the next iteration of this report, next time it comes, that we bring in the summary of the staff stories that we hear through People Committee as well. So we've really got that triangulation across the different range of stories that we hear, and how we can ensure and maximise hearing from the breadth of our service areas and staff, but also hear from some of the seldom heard voices that are harder to present as a story. So, for example, somebody experiencing dementia, somebody with a learning disability, and some people with protected characteristics that might feel less comfortable to share the story. Hopefully that's a clear enough summary, but happy to take any comments, questions or any feedback people want to give at this point.
Thanks, Sharon. I thought the report was really helpful. You know, we have in the past been really good at listening to people in the moment, and then not necessarily so good at making sure that we turn that listening into tangible action. So, you know, this report's valuable in demonstrating, you know, kind of just tying those loops off, as it were. So I'm really pleased with that. Thank you. Sarah.
Yeah, thank you. Really helpful report, and I agree with your comment there, Kevin. And I think if there's a way that we can link back to even going back in further sort of time duration, not just the past 12 months, because we do find themes, don't we? We're not, you know, not listening to families and carers, making reasonable adjustments for people with neurodivergence. It's that. So if we can, as we say with SPC charts, we need more than sort of 7 data points. If there's something that we can pick up which goes a little bit further back, if that's possible. And I really welcome the care and attention that you're giving, Sharon, to how we hear the stories as well, because what we don't want to do through the process is re-traumatize people and cause harm inadvertently. And, you know, people are so brave and courageous, aren't they, to come and share the story. So I think having a different, you know, having more choice in terms of how they share that, I think could be really welcome. So thank you.
Briefly, Kevin, if it's okay, just to come back in.
Of course.
I'd be planning to work with our Council of Lived and Learned Experience on how we do that. There might be different ways that people could tell their story without having to actually come and speak out. As Zoe said this morning, it feels quite strange sometimes if you're speaking into a Teams call and you can't see everybody. So there might be ways that we can just make that feel more comfortable and easy for people. So, but I'll be taking advice from our Council of Lived and Learned Experience on how best to do that. Thank you.
Thanks, Sharon. That's really helpful. Thank you. Can we stick with you then for the next two items? But the next item is Infection Prevention and Control Board Assurance Framework.
Thank you, Chair. So yes, this as well has been through the Quality Committee, and I bring this every quarter. This quarter there isn't change in terms of we're still non-compliant in one area and partially compliant in 2 areas. The partial compliance since having been through Quality Committee around area 4.1, which is around service user involvement and representation, we have now completed that. So when this comes back through to the next round through the governance structure, you'll see that as compliant, but we hadn't done that by the point of this coming through the Quality Committee, which is why it's still showing. And just to give a bit of additional detail to number 5.1 around the infection prevention control assessments on admission. It's partially compliant because we are completing them. We've just got a piece of work to do there to make ourselves fully compliant about the reporting and through to Rio. So just to add that, and we'll make that much clearer in the one next time. And as you can see, the area of non-compliant around fit testing, that hasn't changed since last time, but we have robustly put this on the risk register to make sure we've got that oversight and assurance through health and safety group, and a member of the of my team sits on that group as well to make sure we've got the read across to quality and IPC. But happy to take any comments and questions. Thank you.
Thanks very much, Sharon. Don't see any questions or comments. Thank you for that. I mean, these are issues that are being addressed with the right amount of rigour, so that's helpful to see. Thank you. We'll move on then. We'll stick with you, Sharon, if you don't mind, to item 3.5, which is the safe staffing establishment review, and this requires a decision of the board. So,
thank you. So it's my responsibility as Chief Nursing Officer to ensure that the board receives a full assurance report twice a year in relation to the safe staffing establishment review. So this is one of those twice a year reports coming through. The report aims to detail that we are compliant in line with the National Quality Board and National Improvement, NHS Improvement guidance around safe staffing. So there's two asks here for the board today. One is to be assured that we follow due process and assured in line with National Quality Board guidance, and the other is to seek approval for the recommendation of the uplift of staff on Havenside. What I want to just detail briefly before inviting comments and questions is that we've put in additional scrutiny and governance and assurance around the safe staffing establishment review. So there's now an executive led by myself, confirm and challenge meeting that reports directly into quality committee to ensure there's that scrutiny before coming through. It is a multi-professional group, and I'm really grateful that Mike, our Chief Medical Officer, joined the last one, and I think that was really value adding. We did decline a request for additional staffing within older adults in the psychology provision, but we did support the request for additional staffing in Havenside, and hopefully the report details the recommendation around that and the challenge that was put in around different approaches that could be taken. But this is in line with the additional staffing required when we move to away from dormitory accommodation in our acute wards in Lincoln. So it is in line with what we've done previously. And the decision or the scrutiny that we provided was based on the data, but also on professional judgment and also considering other approaches from different clinicians as well. So hopefully the paper spells it out. I won't go through in more detail, but happy to pick up any questions and comments. And there's two parts for decision, Chair. So one is assurance that we follow due process, and the other is in terms of the uplift of staff in establishment from 35.55 to 43 whole-time equivalents on Havenside. Thank you.
Right, thank you. That's helpful, Sharon, and thank you for the clarity about the two different decisions that need to be made. Can I ask a couple of questions about the financial impact of the proposals? Firstly, am I understanding this correctly, that the financial impact as described in the report don't only include salary costs? So the actual financial impact would be greater than is reported in the proposal, is that right?
So the modelling of the actual financial costs have been detailed through and are sat with the finance team. In terms of, do you mean like the uplift costs and bits, Kevin? Is that what you mean? As in the overheads and things?
Yes.
Yeah, they have all been fully factored in. I'm just checking whether they're in this report, but certainly the finance team were in attendance. Chris is saying he's happy to come in on that as well for a bit more detail with the plan, if that's useful.
And so second question then is about affordability and how that's then factored into the trust's financial planning. So could you just offer a few words on how that works?
Yeah, absolutely. So it will be an additional pressure to the organisation in terms of the additional staffing costs. We have factored it in to our planning assumptions, so we have considered all of that in there, and I'm sure others will want to come in on that. What I would say is if I could draw attention to the board back to our key principles of living within our means and our financial position, we committed to ensuring patient safety, and this has been through the full and thorough safe staffing establishment process. So yes, it is an additional cost pressure to the organisation. It's also one I think essential to meet the basic safety needs of our current patients.
Yeah, Sharon, I'm absolutely not
No,
challenging the need for it. It's you know, how we're going to manage the additional pressure that I'm really interested in. And I ought to apologise to colleagues. I may have missed a couple of requests to comment earlier, but it's for some reason my Teams is not catching up with comment with entries in chat as quickly as perhaps it might. But I've got Chris.
Yeah, thank you, Chair. Just to confirm, sorry, Chris Higgins, Chief Transformation Officer. Just to confirm that the costings in the paper do include all additional on-costs and enhancements for working out on social hours and everything. So it is the full true cost of what the staff will need. And just to say, because we'd essentially approved or recognised the need for these staff as part of the business case we originally approved for the build, and the capital development that we approved as a board. These costs have been built into the plan for next year that the board approved at the extraordinary committee meeting earlier in the week. So they won't be on top of what's already been discussed.
Thanks, Chris. And that's what I was really groping for. You've just expressed it much more eloquently than I managed. Okay, so there are two decisions for the board. The first is, and I'll take them together for convenience. The first decision is whether or not the right degree of rigor and right process has been followed, and then the second is to sign off on the specific proposal about staffing a Haven side. Can I ask colleagues to indicate in chat whether or not they're content with both of those? That's great. Thank you very much, Sharon. Thank you for setting that out so clearly and dealing with my rather ineloquent questions. We'll move on then to item 3.6, which is the learning from deaths report. Mike.
Thank you, Chair. I won't rehash what Sarah Whiteman said earlier on in relation to the Quality Committee report, apart from to emphasise that we're all clear that there needs to be a rebalancing between process and outcomes and learning in this paper. The previous Q1 paper that we had in December and this Q2 paper that we've got today are papers that were already in the pipeline, if you know what I mean. And from Q3, we will start to take steps in the right direction. The report won't be transformed overnight. It will be an iterative process, but we'll rebalance the learning content. So I just wanted to acknowledge that. I'll pull out a couple of particular things that aren't just process and data that I think are important. In the section of the report that refers to the leader process, this is the important and mandated review process for into the deaths of people with learning disabilities and stroke or autism. There were a small number of reviews in Q2, and although no specific learning points were drawn out for Lincolnshire Partnership FT, because the leader process covers the whole system, it's important to acknowledge that both at the system level and nationally, there's been a real focus on suicide prevention in autistic people. And just wanted to emphasise the part of this report that reminds us that our suicide prevention training in LPFT has been updated and modified to include working with autistic people within it. So that's one thing. Another thing isn't in the paper, and it's not strictly board business, but I think it's interesting to know, and I think it will give the board some reassurance that we're sort of stepping up a gear, which is that we have joined the Northern Alliance of NHS mental health trust providers for learning from deaths. Now, I know that might sound a bit peculiar that it's a Northern Alliance. There doesn't seem to be a similar thing in the Midlands, and although they call themselves the Northern Alliance, they're a welcoming bunch of NHS trusts, that they're very happy to have us. So we will be meeting regularly with peer trusts from around the country to compare our approach to learning from deaths and compare our developmental sort of strategies for learning from deaths and its reporting. I'm happy to take any questions, Chair.
Thanks, Mike. And I completely recognise that this is, as it were, a report that's in transition. You know, good to see the direction of travel, and don't expect you to get there overnight. So that's helpful. Your additional observations are helpful too. I don't see any questions or comments at the moment from colleagues. Yes, I do. Sarah.
Apologies, my hand has disappeared off my team, so I do apologise.
It does. You don't have a hand for live things like this. Hands are amputated. Go on.
Sarah Whiteman, non-exec director. Yes, Mike, your reflections on the thresholds for reviews, you know, the number of cases, deaths with patients who are interacting with more acute services. You might argue that you have a higher threshold, but only a few seem to have met it. What just your thoughts, initial thoughts?
We are compliant with the rules that were put in place in 2017 about the application of thresholds that really relate to having an open episode of care or recently within an open episode of care and particular diagnoses and so on. So I think that can be said with some level of assurance that we are compliant with those rules. The question is, how helpful are those rules in terms of thresholding in us actually being able to properly learn from deaths? And the related point is that most of what's in this paper relates to deaths where you might say there is a patient safety consideration, so that the PSIRF process, patient safety incident response framework process, has been invoked. So this would include people who've died by suspected suicide in the community, for example. What the sole focus on patient safety related deaths, or not, maybe not sole, but what the large focus on patient safety related deaths doesn't do is invite us to be curious about the larger number of people who die of so-called natural causes. But the phrase so-called is, I think I used this phrase in the quality committee, that so-called is doing a lot of heavy lifting there, because, you know, to die of a heart attack in your 50s or 60s isn't any longer natural, really. And that is very characteristically a trajectory for people with severe mental health problems, and if you use the diagnostic term personality disorder. So that will be part of what we're doing, is to review the thresholds to take us from compliance to actual usefulness, and we'll continue to give that good scrutiny and stress testing at quality committee, I expect.
Thank you, Sharon. Other Sarah.
Thank you, Kevin. It was just building on what Mike has said, that we've, as a group of chief execs in Midlands and East Mental Health Trusts, we're hoping to work with Centre for Mental Health around Equally Well, which focuses on physical health care for people with serious mental illness. So we're trying to make sure we've got the capacity to engage in that, because I think that will give us some really good insight. But obviously, as a result of support services redesign, you know, we are having to look at our capacity and priorities in terms of what we can engage with. But I think that will bring a different perspective on that learning, as Mike says, if we're able to engage in it. So that's something we can keep the board abreast of.
Thank you, Sarah. That sounds really helpful. Thank you very much, Mike. That's helpful. I'm going to suggest we take a short break for Oh, Mike, do you want to come back?
I was just going to say, in relation to what Sarah said, and the linkage with what we were talking about earlier on into the Lincolnshire unit for mental health research could not be stronger here.
Thank you. I'm going to suggest we take a short break for comfort purposes. It is 10:30, so let's have a short break and start again in 10 minutes time, so 20 to 11. Thanks, everyone. Right, welcome back, everybody. Where have we got to? We are on item 4.1, which is the highlight and exception report from the People Committee. Now, Tim Harry, the chair of the committee, isn't here, so I propose to take the paper as read. If there are any pressing questions or comments, then please let me know. Chief People Officer isn't here either, so we might struggle to have those questions or comments answered, but at the very least we can take them away and answer them offline. Di.
Thanks, Kevin, and I do appreciate the point that you've just made about relevant folk not joining us this morning. My question really was in regards to the part of the highlights and exceptions report that relates to the support services redesign. And in there it talks about there being no impact on several things, but staff sickness being one of them. And the reason that what I'm interested to understand is the time frame over which that staff sickness measure was taken. And the reason I asked the question was because at Performance Committee, when we met, we did note that staff sickness was the highest that it had been since June 2025. Now, some of that may well be seasonal, seasonal pressures, not sure, but I think it would be really helpful if we could just check back around the timings. And I'd also be interested to know, I mean, obviously we look at this through Performance Committee, but I think there is something for us to check in about in terms of staff morale more broadly and, any impact that might be having on staff sickness. So that was really the point that I wanted to raise. Thank you.
Thanks, Di. I mean, we'll take that. I think that doesn't deserve an offline response. I think that's something that we need to circle back to at a subsequent board meeting and ask People Committee, to come back with some specific observations on that, because you're right, it's a significant issue.
Okay.
I've also got if you're content with us with it being handled in that way, Sarah.
Thank you. I wonder if Mike, as Chief Medical Officer, could comment on the GMC concerns around undergraduate medical education. Just be interesting to learn a bit more.
Sorry, Sarah, point me to where you're at.
Sorry, I haven't got it in front of me. I just noted down a question. So I think there's joint action with you and Amy Beaton as the Chief People Officer to look at undergraduate medical education concerns.
Oh right, sorry. Yeah, this was a very specific thing. We haven't, as an organizer, it's not concerns. We haven't historically, as an organisation, reported our performance around undergraduate medical education through into our governance. Because of that, a paper was asked for and arrived at People Committee setting out the lie of the land in relation to undergraduate education, and it was largely descriptive, wasn't performance orientated, and so was helpful in one sense, but needed to be something a bit different in another. The other thing to say is it was probably in the wrong place. It probably didn't belong at People Committee. It belonged at People Oversight Group for the group to do the heavy lifting on it and then bring some kind of higher level synthesis around undergraduate medical education to People Committee. What I can say is that there aren't current concerns from either the GMC or the University of Lincoln Medical School in relation to the way that we're doing undergraduate medical education in LPFT. It's more about taking those initial steps to get our reporting a lot about that more formally plugged into our governance.
Thanks, Mike. Thank you, Sarah. We'll move on then to the next item, which is item 4.2. Chris Higgins.
Thank you, Chair. So I'm presenting what is essentially two reports, but they're both combined because they both fall under the realm of the equality delivery system. One half, which is domain one, which is about commissioned or provided services that focus on health and equalities for patients, is under my responsibility as Chief Transformation Officer and is managed through the Health and Population Committee, and the domains 2, which is workforce and health and wellbeing, and domain 3, which is inclusive leadership, are managed through by Amy Beaton, Chief People Officer, through the People Committee structures. And just to say, both reports that we presented today have been through those committees and recommended for approval by the board. And the decision we're looking for is to submit the results of the Equality Delivery System reviews to NHS England to publish the results on our report, which is a requirement of the NHS standard contract. And also there's a specific request just to say about including the Equality Delivery System as part of the annual equality report, which seems to make sense. Just to say, in terms of this, it's a requirement, I say, through NHS standard contract. It's a tool for us to be able to use to be able to understand how inequalities are experienced or across the organisation, both for staff and service users. There is a score at the end of this, which you'll see in the reports. Each domain is scored individually. The sum total of those scores gives us a position. We scored 20 overall, which puts us in a developing category. And just to say, that's a 4-scale category ranging from underdeveloped, developing, achieving and excelling. And we're in that second level of developing. There are corresponding action plans linked to each 3 domains, and they'll be managed through the respective working groups and reported through to committees. If I just focus particularly on domain 1, just to say what the process is. You pick 3 services as an organisation. We picked perinatal services, community rehabilitation services and Langworth Ward after consultation with the operational services. And there's a deep dive into the experience of patients who accesses those services, outcomes, patient experience, what people are telling us. And from there we discern a number of different factors that might give us insight really into how people experience our care. Just as some broad headlines, I won't go into it, but there's a growth in the number of people accessing most of those services. We've got underrepresentation from particular groups, ethnic minority groups in others, relatively young people using some services. So we've got a great level of intelligence, but we've also identified through that process that we've got some gaps, particularly in the reporting and recording of protected characteristics. So as people come into contact with services, we're not always capturing that information, which means it's quite difficult for us to get a true understanding of who's using services and what their outcomes are. So much of the action plan around that domain is linked to making sure we've got really good data and working with the teams to improve that. And so that action plan, I say, will be reported through Healthy Population Committee. In terms of domains 2 and 3, again, piece of work undertaken led by the people team. Domain 2, the areas where we're I think where we've got most need for most improvement was around health and wellbeing support for staff, inequality experience of harm. So again, we know that through other reports around particularly our BME staff and disabled staff having disproportionate levels of reporting disproportionate levels of harm. And then for domain 3, it predominantly around how we're reporting and governing equality and diversity impact assessment. So for example, what we were capturing in board committee papers, making sure that we're doing this equality impact assessments in the service changes that we do and reporting those through, and then monitoring the follow-up of any impacts that we identify. So again, action plans are in place to make sure that we're correcting those as we go forward. So so that's probably all I probably need to say in terms of introducing the papers, but if there's any questions, happy to pick them up.
Thanks, Chris. So just to reiterate, all of this has gone through a degree of rigour at committee, and the board's being asked this morning to approve the results of that for submission to NHS England. I've got Di first with a question and a comment.
Thanks, Kevin. Thanks, Chris. I Di Bailey, non-exec director. I found the report really interesting, and I think it might be the first time that we've had all domains reported on, if I'm right, in terms of that domain one. So very happy to approve it going forward. I thought it was really useful. My question relates to the data that we see at performance committee, particularly in that space that aligns with domain one around patient experience. And it struck me when I read the report that some of what is in there almost overlaps with what we've got, what we see, or we've got as some of our key performance indicators for performance committee, albeit without that kind of health inequalities lens. And so it left me with a question, given, as you've mentioned, the new Healthy Population Committee coming on stream, just how we might get a bit more savvy, I suppose, around what we see in Performance Committee and how that aligns with what you're looking at in Healthy Population. And I guess how we might use resources to best effect so that we're not duplicating information going to two places but for different purposes. Thanks, Kevin. Thanks, Chris.
Thanks,
Yeah, thank you. Great questions, Di. So one of the key actions within the EDS action plan is to making sure that trust chairs apply an health inequalities lens to the work that we're doing, and we can see that being reported through in the discussions and through the papers that we produce. So there is something about how we're making sure that we enable that to happen through the reports, but also that inquisitive mind around health inequalities. What I would say is it's a tricky one. EDS is a tool for us. There are other tools, PCREF, that we've obviously spoke about before, and a wide range of different, certainly from a workforce perspective, we've got the RES, the DES and other things. So there is overlap between these pieces of work, and certainly the approach we're taking from a health inequalities lens is we're pulling together through Healthy Population Committee is one health inequalities report that encompasses everything, of which EDS forms an important part. In terms of the reporting though, and that's what we're working on now, is we need, probably as part of our IPR, to understand, or we can work out the best place to report it, but a suite of metrics around health inequalities, and so that we've got much greater line of sight both at a service level, at a care group level, and at a performance committee. And in terms of that capturing the right data quality, we're hopeful that patient engagement portal that we've agreed to develop will really help us patients take greater control over entering their own demographic information. We can hopefully enhance it through that way, but still more work to do on that.
Thanks, Kevin. Thanks, Chris.
Thanks, Di. Sarah.
Thank you. I just wondered about timescales, given that we can't be absolutely sure we're delivering equitable care with all the data gaps in the demographic data. I wondered what the likely duration would be till we were happy with the accuracy.
Well, that's a $1 million question, Sarah. The action plan we put in place is intended to correct the gaps within the forthcoming year. So that's the time frame we would expect it from an EDS perspective, is putting actions that will be implemented in the forthcoming year. I think some of it, it's probably unrealistic to think we'll get 100% accuracy on, or completeness, should I say, not accuracy, but completeness on data capture, because there's always going to be an area of because of the way we manage services turnover and different people and way people engage with services. That said, some of the areas we're way off on where we need to be. We're way down on, for example, recording disability in some of our community rehabilitation team and perinatal services, way down on recording sexuality, sexual orientation. So there's 100% completeness. I'm not sure that's attainable. Can we have a significant improvement within next year? Absolutely. I don't want to put a figure on that today, though, if that's okay.
Thanks, Sarah. Thanks, Chris. I'm assured by the kind of rigor that's gone into producing this report, and yes, there are gaps have been highlighted and some triangulation to be done, but I'm content that this is in a fit state to be submitted to NHS England. I'd be grateful if colleagues were able to confirm that they are too. That's great. So you got board approval, Chris, to go and press the button and send those off.
Thank you.
Thanks very much. Muted myself unintentionally. We'll move on then to item 4.3, which is you, Mike, the Guardian of Safe Working report.
Thank you, Chair. I propose we receive this item as if it were a consent item. It's been previously received at People Committee, where it was found to be assuring. I will point the board to the final sentence on page 1 of the report. The Guardian of Safe Working is assured that resident doctors in LPFT are working in accordance with the terms and conditions of service. Thanks.
Thanks, Mike. That was short and to the point. I'll take any quick questions or comments that people may have. Otherwise, we'll just take that to note. Excellent. Thank you very much, Mike.
Thank you.
We'll move on then to the highlight and exception report from the Best Use of Resources Committee. Chris.
Thank you, Kevin. Chris Wright, Non-Exec Director, Chair of the Best Uses of Resources Committee. We last met on January the 8th. As colleagues know, and the Trust has been running a Living Within Our Means programme. The Best Use of Resources Committee is keeping oversight of that. We're really we welcomed the latest updates and the progress that have been made in relation to that, which is keeping the Trust on plan in relation to its financial circumstances. The reality is it's not going to get any easier. We need to keep focus on all the activity associated with ensuring that the Trust remains a sustainable organisation, and the latest financial planning round is going to make our responsibility to do that even more relevant. In addition to that, we received a deep dive into, it's a very technical issue around the apportionment of cost. It was a dense report, I mean that in the most positive way. A lot of really good insight into how we're applying our methodology. There needs to be some further tweaks to that. And we're doing some further work across the Trust on that methodology and ensuring that it's fully applied across the different functions in the organisation. And we received two papers in relation, well, one paper in relation to two future procurement processes relating to our IT, one of which related to the patient record system, and the second one, our IT support services. We're just getting well ahead of where we need to be so that those processes can run smoothly and we can test the market and ensure that we can procure decent systems and support. And finally, we received the State of Readiness report in relation to our preparedness for emergencies, resilience and response, and recommend that to the board.
Excellent. Thank you very much. Chris, any questions or comments on that? If not, we note all of that and note your commendation of the last report that you mentioned. Thank you very much for that. And we'll move on then to the highlight and exception report from the Performance Committee.
Thanks, Kevin. Di Bailey, Non-Exec Director and Chair of said committee. Just to note, really, this was the last meeting of the Performance Committee that was looking at performance from the divisional structure. We recognise that going forward that will move with the move to care groups, and we had a presentation during that meeting around the lines of accountability through the directors of ops that will be that is associated with that shift to care groups. So for that reason, Kevin, the committee resisted making any further changes to the part of the integrated performance report that you will see in a minute that includes the balance scorecard. Work has continued on the balance scorecard behind the scenes, as it were, in readiness for the shift to care groups, but we've resisted reporting at this stage. So I look forward to that in future. I think it was fair to say, and I don't want to steal Eve's thunder in a second, but I think it was fair to say that a lot of the key performance indicators in the integrated performance report that we looked at had not significantly changed from the previous performance committee, which was in November, to the one that we had in January. Apart from, we continue to see challenges around our and fluctuations in our out of area use of beds, although that is improved from when it was at its peak earlier in the autumn to within our target. But the continued challenge that we have is really around the discharge for people who are clinically ready to leave our services. We did note the real progress made in the multi-agency discharge event that's been held, and that should hopefully get us to a more effective position in the future. But I think there still remains a challenge in that space, and it really is about how we continue to work with our local authority colleagues in the space around adult social care and placements for people that I think will continue to cause us continued challenge. So I'll stop there, I think. Thank you.
Thanks, Ty. That's very helpful. Quite agree with the approaches that you're taking. Any questions or comments for Di? Don't see any, Di. So thank you very much for that. Note that report. We'll move on then to the integrated performance report, which, Eve, I think you're presenting for us this morning in Mark's absence.
Yeah, thank you, Chair. So I'm going to take the report as read, as always. A reminder that the integrated performance report provides an assessment of organisational performance across quality, access, people, finance, patient experience, so covering all areas of our trust strategy. And I think what we can see is, while we're continuing to make progress in our long-term strategic aims, there are some operational and system-wide pressures that are continuing to impact performance. So in terms of quality and regulatory assurance, Sarah's already referred in the Chief Executive report to the CQC inspection of our mental health rehabilitation inpatient services. We received a rating of requires improvement, which was driven mainly by concerns on the veils that we've been very transparent about prior to the CQC visiting. However, the CQC did recognise that significant action was already underway, including strengthened leadership, improved governance, clearer escalation, and they commented on the compassionate and respectful care that patients received on the wards. There were no conditions applied to the trust registration, following a really strong demonstration of our ability to evidence the actions and that we needed to take, and there are ongoing priorities, including sustaining safety improvements, embedding physical health competencies, and assuring consistent high quality rehabilitation care is what we're able to provide on that ward. In terms of operational performance, some significant improvements are contained within the report, including a 38% reduction in the Veterans Service waiting list following the introduction of a new assessment clinic approach, and that's been part of what we've been looking at through the Courage approach to productive pathways. Despite the positives, there are some areas that remain challenging in terms of operational performance. Talking therapies, completed treatment target. We're forecast to deliver 95% of plan now. We're doing a deep dive to understand that, because what we've seen in our initial look at the data is we're not doing any less activity within that service. So we want to understand, we believe that we may be doing more assessments and less treatment at the moment, and we need to understand how we can redress that balance. Di's already referred to the challenges around out of area, and though we were in a good position of 0 people being placed out in inappropriate out of area placements by the end of the year, that is, we achieved that at a time of really high occupancy and some real challenges around discharges. And in the current month, we have seen more people placed out of area, though the majority of those are still placed within Lincolnshire, but in a non-NHS bed. Adult social care performance remains fragile, and we've got high numbers waiting assessment and overdue reviews. We have got a recovery action plan in place for that service. We also can see in the IPR that autism diagnostic waits continue to grow. We've now got over 400 people that have been waiting over a year for waits. We're doing a piece of work again through the productive pathways work to look at our approach to that and how we might make changes in the way we deliver services to improve that position. In terms of access and waiting times, we continue to report against the national waiting time standards of 4-week wait. However, we know that the national standards are assessed against specific activities that have to be recorded to stop the clock. So we're also reviewing our actual waits completed in terms of from a patient perspective at the point that somebody is seen, as well as monitoring our performance against the national standards. And what we see in that is that our performance from a patient experience perspective is much higher than our performance when we look at the national activities that stop the clock. In terms of our crisis response, we have seen significant improvement in our adult crisis services in terms of the national targets around very urgent responses and urgent responses. We are seeing challenges in our children and young people's crisis response times. However, we've done the deep dive into that, and we are recording the majority of appointments into children and young people's services as urgent, when nationally only 5% of referrals into crisis services are recorded as urgent. So there's a piece of work going on there to understand why we're an outlier in how we're grading those, and if we get that right and become more consistent with the approach nationally, what will that do to our performance? In terms of workforce, we're seeing some steady progress, both in terms of supervision compliance. We're seeing an improving trend for management and clinical supervision. Vacancy rates have begun to fall from their peak, and turnovers showing sustained improvement over time. The Trust continues to implement changes arising from the support services redesign and the wider Living Within Our Means programme, and we're also preparing for the new NHSE leadership framework. In terms of experience of care, our service user experience remains strong, with 90.8% rating their experience as good or very good, but feedback volume remains low relative to activity, and there's limitations in how we currently capture data. We're really hoping, as we move to the patient engagement portal, that we'll see much more higher numbers of people responding, which will hopefully be able to give us much more confidence in the accuracy of what we're seeing. In terms of finance and use of resources, the Trust remains on track to deliver its planned end of year deficit. Year to date, the deficit is slightly favourable to plan, but we are forecasting hitting plan. Agency spend is 0.5 million below plan, with overall use remaining low at 1.6% of the total of staffing costs. So that's really positive for us as an organisation, and we know the links between good quality patient care and less use of temporary staffing. Cash and capital positions are below plan, largely due to prior year closing balances and VAT reclaims, but the forecast remains stable. Any financial risk continues to be actively managed through the Living Within Our Means programme, and we've got a real focus on recurrent cost control and productivity. Finally, in terms of transformation and outcomes, we're progressing the work on ensuring that we've got routine, meaningful outcome measures across services. Though trust-wide reporting isn't yet fully established, we are seeing increasing compliance. And what we've agreed to do is start to report from the areas where we've got good compliance and paired data, to start to use that data to report on the effectiveness of the interventions that we're offering. And we're expecting major digital and clinical service improvements, such as the patient engagement portal, looking at a different assessment template and a quality audit app. So all these things are in progress. And I think I'll leave it there, Kevin.
Thank you, Eve. That was a very comprehensive canter through all of that. And I think you may well have headed off questions from colleagues, but I will invite people to indicate whether or not they've got questions or comments. So I've got Chris Wright first.
Thank you, Kevin. Chris Wright, Non-Executive Director. It's not a question, actually, it's a comment. I just wanted to just express my appreciation for all the hard work that's gone on in relation to our performance in connection to the financial plan this year, because it's been a very tough plan, and there's been a high level of commitment to achieving it. And the as I referred to a moment ago in the Living Within Our Means programme, the level of rigour and commitment to keeping to plan has been exemplary. Thank you.
Thanks, Chris. Just want to echo that. I think that's absolutely right. Any other questions or comments? I think take the absence of questions or comments, Eve, as a reflection of the fact that the skill with which you've presented that, and the fact that you kind of drawn out the main points, and you've certainly preempted the questions that I was going to ask. So that's excellent. Thank you very much.
Thank you.
We don't need Mark back. Eve, you can do it in future. We'll move on then to the next item, which is the Lincolnshire NHS Charity Annual Report. Di.
Thanks, Kevin. Di Bailey, Non-Exec Director and member of the Charitable Funds Committee for LPFT. I want to say probably three things relating to the report itself, and then I suppose something around the kind of strategic direction, really. So, if you look at the report, I think it's really clear that there have been some fantastic activities and opportunities throughout the year, which notwithstanding the amount of money that they've raised for the charity, the real value that they add in terms of morale and well-being and the good that all of that activity does. So I don't want to detract from that at all. But I think if you look at the detail of the report, you can't get away from the fact that donations and income from sort of grants is down. And actually, the overheads have increased significantly. They've doubled. So at a time when we're looking at best use of resources and living within our means, we've got a challenge there, I think, going forward. And I think what isn't clear from the report, Kevin, which I would want us to urge to include in the future, is something about how long it's taking to get funds distributed to where they need to be in proportion to the amount of money that we're distributing. So there are, sometimes there are bigger grants being made which require more due diligence. There are some, and that's right and proper, but we need to have sight of that, I think, going forward. So those are my comments about the report. in detail, I think. In terms of the strategic, we're working in a slightly different space now around this, as with the group model. The trustee of the charity is United Lincolnshire Hospitals Trust, and Chris Higgins and I have got a couple of meetings in the calendar to talk about that strategic direction going forward. So I think for me, there's a trade-off if we're going to stick with an NHS charity model, which is what we've got at the moment, which is about, what doors does that unlock for us around those grants and those funding opportunities vis-a-vis the constraints that we might have around how the whole thing is managed. And I think we need to have that conversation with partners in terms of ensuring that we absolutely maximise the best use of these funds for the most benefit to our communities. All of that said, I think at this position, at this time, with the report as it is, I think the report is here for approval, and I'm supporting that, notwithstanding the caveats that I've outlined. Thank you.
Thanks, Di. A couple of quick observations from me. That, and colleagues know that I'm hugely exercised by the fact that the charity currently only has one trustee. Despite the way in which the report is written, there is in fact one corporate trustee, which and LPFT is not a trustee of the charity. So, we have no legal locus over any of the decisions that it takes, and that exercises me greatly. But that plays to your kind of strategic point. And the other is, on the face of it, the costs of the charity compared to its income are massively disproportionate.
Absolutely.
And I wondered, Di, whether you had anything to say on what the current trustees of the charity are doing about that.
I think that's all part of the conversation that Chris and I are having going forward, Kevin. And I think that's the issue. I think to go back to your previous point about the trusteeship, as I understand it, but I may be wrong, because it sits within the legal governance of an NHS charity. We can only have one trustee. So, as I say, I may be wrong about that, but that's my understanding. So I think there's that issue to bottom in terms of whether we should take it out of the NHS, which might give us more flex around that. But absolutely, I agree that we have to address the overhead issue. But Chris and I have got the meetings in our site. Chris Higgins, I should have said. Thank you.
If that's right about there only being possible only to have one trustee, that's the first time I've heard that view expressed in the more than 10 years I've been involved in the Lincolnshire NHS charity, because when I was a non-executive director at LCHS and we were the corporate trustee, then no one ever said that at the time. So I'd want to be absolutely sure that that's the case. I'm not convinced, but
Okay, no, but fine, Kevin. As I say, I'm not sure, but I'm sure when we had the conversation before that was the reason given, but I may be wrong.
Okay, all right, thanks, Dyke. I've got a comment from Chris Higgins.
Just to kind of say on the back of that, there's a real commitment from our colleagues in the hospitals group to really look at this and to think about different ways of achieving what we're trying to achieve. So ultimately, I think to your point, Kevin, around different form and trustee input, we'll have some options, I believe, at the end of this that we can consider as a board and work out what's best interest of LPFT.
Yeah, thanks, Chris. That's all I really want. So I'm happy with that, and I just will continue to chunter on until we are in a position where we're confident that the best interests of LPFT are written in all of this. Chris Wright.
Thank you, Kevin. Chris Wright, non-exec director. Thanks, Di, for setting up the strategic conversation, and Kevin for your comments and observations. Clearly, this charity is suboptimal, and I think it's another example of the NHS try to hold responsibility for everything, as opposed to thinking much more imaginatively about how it could use charitable funds or collect charitable funds to support its wider aims. And I really think we need to have a proper look at this and think about how those aims and objectives can be better fulfilled by making more use of existing charities or VCSC organisations across Lincolnshire. It really doesn't make any sense if you look at this for cost versus the level of income and reserves. I just think we need to be very radical.
Yep, I don't argue with that for a moment, Chris. I think you're absolutely right. Okay.
Thanks, Kevin. It's good to have the board support as Chris and I go into those meetings.
Yeah, thank you. That's really helpful. Thank you very much, Di. All of that's noted. We'll move on then to the highlight and exception report from the Healthy Population Committee. Chris.
Thank you. I was so busy putting my question about charitable NHS charities together, I forgot about this. Chris Wright, non-exec director and now chair of the new Healthy Population Committee. Chris Higgins actually helped set this up earlier when he was talking about the equality delivery system and health inequalities per se. This is a new committee. It's been established by the Trust to have oversight of our strategic ambition around what we can do to contribute to improving the lives of the health and lives of people across Lincolnshire from a healthy population lens. So it's early days. The committee is strengthened by the co-opting of a local authority public health consultant, Lucy Gavins, and she joined us, which is excellent. And we're looking at how we can encourage, influence, oversee the development of broader community capacity and services designed to help keep people away from more formal interventions, as well as ensuring that those health inequalities are properly surfaced, identified and addressed, so people can access the support they need when they need it across the county. So I'm very encouraged by the commitment to this new committee. As I said, it's early days. We need to ensure that we have a clear plan in place, and we will be holding the Trust to account in relation to its healthy population commitment and its strategy. Thank you.
Thanks, Chris. I think as a board, we really welcome the new committee. Absolutely concur with what you say about the committee's approach and purpose. So that's really helpful and supported. Look forward to the future work. Any questions or comments for Chris? If not, then we'll move on to the report from the Audit Committee. Ian.
Yeah, thanks, Chair. Yeah, I'll take the report as read. We met only 2 or 3 weeks ago on the 22nd of January. Covered a range of issues, as the report I think makes clear. There are a couple of things that I probably just want to mention, and really they're both around internal audit. The board will know that internal audit conduct a programme of work every year, and I think the good news is that plan is progressing well and will put us in a good position at the year end. And within it, most of the reviews that have been undertaken have given us substantial assurance. That's the internal auditors term that they use there. So that is good news. However, on the other side of the fence, we have received a couple of limited assurance reports, which we will need to work on. And I would mention, as has been mentioned earlier today, the fact that one of those limited assurance reports relates to the effectiveness of our clinical audit arrangements. So that's obviously an important area. Now, the good news is that the board should note really that that whole issue is being addressed at the moment, and that the quality committee are providing oversight of that. But clearly, in my role as chair of the audit committee, I'll continue to pay close attention to that, and certainly in the not too distant future, I'm sure that our internal audit colleagues will follow up on some of that work as well, to give us an update on the work that's been undertaken to date. So that's all I wanted to say. Any questions, I'm quite happy to try and answer them.
Thanks, Ian. That's really helpful and self-explanatory. If there are any questions from colleagues, happy to take them. Excuse me, I'm about to cough. Bear with me for a second. Apologies for that. I don't see any questions or comments, Ian, so thank you very much. We note that report. We'll move on to the next item, which requires a decision. Karen, it's you, the review of the Trust Constitution.
Thank you, Kevin. So as you say, this is the Trust's annual review of its constitution. We choose to do an annual review. It's recommended. We're not obligated to, but we do one. We carried this out at the back end of 2025. The highlighted proposed amendments are summarised in the paper. These have previously been considered by the Council of Governors at its meeting at the end of January and were approved subject to the board's approval, as it's statutorily required to have joint approval and sign off. So won't go into any detail unless anybody has any specific questions or comments, Kevin. Thank you.
No, thanks, Karen. It's all quite self-explanatory, I think. Just check whether or not, sorry, I'm having a slight technology hiccup. Just checking whether or not any colleagues have got comments or questions. I don't see any, so if I'd be grateful then if colleagues could indicate that they're content with the changes as proposed. Thank you. Is there anything while you've got the floor, Karen, that you particularly want to bring to the board's attention on the next item, 8.1, which is the forthcoming board programme, or shall we just note it?
No, I think it's just to note, Kevin. Thank you.
Excellent. Well, we note that too. I will move on then to item 9.1, which is the investment appraisal framework. Chris.
Yeah, just to note that this is the annual review of the investment appraisal framework. There's 4 key changes this time that have been through Best Use Resources Committee and recommended for approval to the board. One is we've established a new business development major capital group, and that's to make sure we've got more agility on business decisions, a place to really properly monitor and scrutinise the business development pipeline and income generating opportunities. And as I say, just hopefully it will give us a bit more alignment to our strategic ambitions around healthy population and other areas of strategy. We've consequently updated the thresholds that are affected by that introduction of that new group. We've also put in a process just to be clear around, for everybody to be clear around the withdrawal of services. So much of the investment appraisal framework is about setting up new things, but we have got obviously recent experiences where we're coming out of services. So having a process laid down in terms of what thresholds we need to take to what committees for what decisions, we're just mirroring that in the investment appraisal framework. And then finally, just to say, we have put a small section in there around establishing subsidiary organisations. That's not to say that we're doing that at this stage. We're still considering options as an organisation, but just setting out the process we want to go through for approvals if we decide to pursue that as a opportunity. So that's all it is. It's been through the relevant committee and is here for final approval.
Okay, thanks, Chris. As you say, it's been given scrutiny appropriately at committee, so I'm not expecting to have massive objections at this stage. Are there any questions or comments from colleagues? If there aren't, people would be grateful if people could indicate whether or not they're happy to approve it. Thank you. Thanks very much, Chris. And then the final item, which is also for decision, standing financial instructions and scheme delegation. Karen, I assume you're stepping into the breach on this in Mark's absence.
Thank you. Yeah, I did lead on the working group that was set up to carry out the Trust's annual review of these two key governance documents that are set before you. So I think the paper is quite self-explanatory. We've attempted to provide a high-level overview of the proposed amendments to both documents within the main report. These have all been scrutinised previously by the Audit and Risk Committee at its meeting more recently, and they have recommended approval by the Board of Directors. It also cross-references neatly to the previous item that Chris presented on the investment appraisal framework, and just to provide confirmation that those changes have been cross-referenced across to the scheme of delegation to ensure consistency. So I don't propose to go through them line by line, Kevin. As I say, hopefully it's self-explanatory. Happy to take any questions or comments if required.
Thank you, Karen. Let's get the right window open so I can see whether or not anybody's got any questions or comments. I can see that there might be one on its way, so bear with us for a second. So quite a tease, because you never know whether, when you see somebody's typing, whether or not they're about to pop a comment or something in chat or not.
Quiet.
It looks like not. So I'll invite colleagues to indicate then whether or not they're content to approve as proposed. And the answer to that's yes. So thank you very much, Karen. And that concludes the public element of this morning's Board of Directors meeting. Thank you very much, everybody, for your attention and your engagement in this morning's discussions. I'm going to propose that we take a bit of a break before we reconvene in private. It's now 11:30. Let's reconvene at midday. Colleagues are content with that, so I'll see you all in a bit. Thank you very much.
Thank you.
Thanks, Kevin.
Thank you.